This is Tamara Meyer. So while Dr. B is coming back to his sleep, can you get the clicker? Okay, and put it up. He and I will be moderating the session, sort of. I mean, it's kind of a free-for-all up here. We can all call on you with questions. But so we're going to put the first, and we're going to ease you in with, I think, one of the harder questions first. So we'd like to discuss the analytical approaches that enable inference about the underlying population without having to know about the selection process or without making any assumptions about it. And then sort of a second part of that question is to discuss the utility of making assumptions about the selection process and the assumptions that we might consider reasonable. And Scott here will be writing down the names, and we'll try and keep you in order and keep you in line. So who would like to begin the discussion on this question? Dr. Novak?
Yeah, I think just sort of opening it up, it's very challenging to say, well, we're not going to make any assumptions about the selection process. I mean, that to me is sort of akin to trying to kill an elephant with a dart with a blindfold on. I mean, it just seems really impossible. So I think you need to make some preliminary assumptions about the selection process through which individuals are potentially, sampled. And that sampling can be either two ways, sort of purposefully, and you can use something like quota sampling to make sort of an adjustment where it's not sort of, you're not a priori, making a list and then sort of sampling people from the list, but rather you're organically taking people to fit some, population characteristic. But I think one of the things that statistics, I think, needs to do a better job of, or there needs to be better communication, is developing new sampling approaches that don't necessarily rely on sort of the standard, a priori, here's your sampling frame, here's, you're going to select every kth element, because I think when we get into this notion of prescription drug abuse, and you have abusers that are hidden in so many different parts of the system, you have your general population surveys, and so those are really good if you want to just pick up, how many people have ever abused or misused a particular drug. I think that's okay, and then maybe you can get into some preliminary notions of dependence. But I think where we get into challenges is that when we need to look into these patchwork systems like treatment center data, and even then, I think we often think of treatment centers as being this one homogeneous population, but if you dig further, you have the selection process of how people get into treatment centers. Are they self-remanded, or are they remanded through drug court? Are they in general outpatient? Are they in office-based buprenorphine treatment? Are they in private inpatient services? And those aren't all the same. Those aren't all the same people. And when we say, well, what's a treatment center? When we look at some of these data sets like TEDS, well, it's a treatment set, but it's they collect some specific kinds of information. So I think we need to, my point is, I think we do need to do a better job of at least trying to understand the population assumptions, trying to understand the hiddenness of the populations, and trying to understand our blind spots, and then try to advance our statistical methodologies, like non-proportional methods, quota sampling methods. I know that people are looking at internet sampling as sort of this new era to do a better job of getting hidden populations, especially getting people from the dark web, sampling people from Alpha Bay while it's down, but some of these other sort of markets where you can go on chat rooms and get people into surveys and learn more about them, and then track them over time. So at least that old saying where a clock is wrong, but it's wrong it's correct 2 times a day, but at least we can start to understand trends in certain proportions. So I guess we also sort of then need to think about, what's our metric? Do we want to make an inference about the general population, or in some specific populations that may or may not be generalizable, do we see changes over time in response to environmental presses like, different policies and policy shocks? So.
Thank you.
Sorry, I think that there's definitely a need for a lot of different data and looking at administrative data and seeing what we can do with it. We also do have the issue of declining response rates, and those do adversely affect the quality of our data. But I think there have been other snowball samples, network samples to get rare populations, so there are a lot of areas that I'm sure you're knowledgeable about. But I think as federal entities making these large-scale decisions, we always run the risk when we use non-probability samples of just simply not knowing what some of these differences are and not knowing if there are underlying mechanisms that are affecting who's included in the sample and who's not. And so definitely it's an area of further growth, but in the survey methodology and the data field, there really hasn't been a lot of answers provided. And so we are almost talking about doing groundbreaking research prior to actually implementing it versus taking things that have been done and then using them. And even within, and I agree that sometimes you cannot get a nationally represented population, but there are specific populations that you're interested in. And if we could look at those populations in a very meaningful way, that would make sense. But even if we were to use the example of the dark web and go in there, and I'm not very knowledgeable about the population, I will say, if the nature of that population as we define kind of changes over time and we start making assumptions about them and how they're behaving without controlling them in any kind of way, we don't know who's coming into the sample, we don't know who's exiting the sample, and therefore we don't know if any of the inferences that we're making about these populations hold. And that's the risk. And that's not to say that traditional surveys are without their risks. They have coverage issues and we have response rate issues. And so I think that for FDA and other federal agencies, any foray into these convenient samples, we're still not at a point where we have good processes and metrics to use.
Dr. McClure, then Dr. Novak.
This may spill over into discussion tomorrow, but additional factors that need to be taken into consideration are patient behaviors. When we look at laboratory type testing with drug testing, we find that in patient populations where we're looking at somebody prescribed the drug and they're monitoring for that, 54% of those results, 3 million results that we look at, we find that they're inconsistent with what's indicated as being prescribed by the ordering physician. In those inconsistent results, we see drug substitution, we see drug supplementation that's out there. And some of these factors are going to affect any of the data that you're collecting here, assuming that you've got compliant patients. You need to understand the behavior of those populations. Maybe you can use ICD type coding, whether it's retrospective ICD-9 from years past or ICD-10 currently on there. And again, this may roll into discussion that we'll have tomorrow too for metrics.
Dr. Novak?
Just quickly to respond to the one of the previous issues, I think we don't want to get fallen into this trap of like we know what the population are, because I think everything is a degree, right? We have certain expectations that we know, like even in some of these surveys, like the National Survey on Drug Use and Health, but I mean we still go to meetings and we still hear people talk about it as a household survey, and it, that term has been dropped for well over a decade. But it just shows that people either don't understand what's in that sample and they think it's just a household and that's it, or the people that are running the survey think that there's just this sense of, whether we know that there's an imprecision, but people live at a certain address or what, but we do make an assumption that it's a little bit more precise than, let's say, a quota sample. So I think, we need to sort of break this binary thinking of like capital T truth versus this is validated and this isn't, and do a better job of understanding the gradations. And I disagree that we need to make like major shifts or major groundbreaking statistical advancements to get to where we need to go. I think like in all places of science, there's some really innovative work that's being done in other places, like computational biology and how you sample cells and different genes and gene deserts and how do they, that's just really amazing stuff that some of our survey methodologists are learning from, and there's this cross-fertilization that happens. So I do think that we do have some answers. I think we need to sort of break this binary thinking of like, this is we know this with a capital T and this is truth, and then start to move on and then look at degrees of acceptability, and I think the challenge for groups like ours is to figure out, okay, well, where does that threshold really lie where we can say, well, we sampled something from the dark web, is that completely, a wash and that's just as simple as a convenience sample? Or are there circumstances when you can actually move that needle a little closer to not necessarily the threshold of a probability sample, but at least move it away from it being a complete convenience sample, because if you know some characteristics of the people, you may not know their address, but you may not know where they live, and you know some demographics, and you can start to, as Dr. Bai was saying, understand some of the selection processes that get people into these different places where we sample. I think that's going to help us elucidate the characteristics of the population and get us where we need to go, because doing these big national samples, it's just not, they're so expensive. I mean, not everybody has $50 million to play around with. There's only, Monitoring the Future and NISDA and some other places have that kind of cash to throw around, and you can't ask those surveys to do every single thing. I mean, they gotta, NISDA is a congressionally mandated survey that's supposed to help the states populate their, treatment block grant and their prevention block grant, and now we're asking it to do all these other things for the FDA. So I think we need to be very creative in terms of using the resources and the science that we have, and being very, very creative in trying to identify these, levels of truth, so to speak.
Sid Schnall, taking maybe a more simplistic approach to this, I'm not a statistician like some of you are, but it seems to me that there are two big blocks that we need to look at. One, the patients for whom the drug is being prescribed, how do they deal with it, what's going on with them, and looking specifically at that group. And then there's the other group who, as Dr. Henningfield said, those who are getting prescription drugs for which there was no prescription to them. And that's a different group. And I suspect there are very different behaviors in those two groups. And as Scott pointed out, particularly that second group is a very complex group involved in a lot of different things. So, when we're looking at this, I think trying to break the buckets down to some extent so that they're more meaningful can be very helpful. And, looking at a large survey like the National Survey, Drug Use and Health, you're covering populations, so there are a lot of different things going on. And some of those people are patients and some are not. And looking at that, and we have to look at that, of course, with the specific drug of interest. And as we've learned from the data, that's a small group. We've got a very small denominator, and that can be a big problem. So I think if we can break it down to meaningful groups, it might be a little easier to understand what's going on rather than trying to do it with one large sample.
Thank you. Go ahead, Dr. Grobart. Go ahead, Dr. Grobart.
Barry Grobart. I feel that there are different objectives here, okay? And depending what your objective is, like the previous speaker said, would require different statistical approaches and also sampling, estimation, everything else. You have to kind of lay these out. National surveys clearly have an enormously important role for broad, and particularly this national survey of drug use survey, household survey, provides FDA, if they were to use it along these lines, I'm sure you are doing that, provides some sort of broad brush idea of what's going on in the population, in the general population that survey can get to, okay? But if you want to get to patient questions, then clearly you want to develop a target population around patients, and you should, this gets into the next day about, possibly new data sets, but there are some patient surveys that are going on at the National Center for Health Statistics, the hospital health survey, whatever it's called now, and so forth. And so you can address those questions. Also, this idea of using very non-standard type, looking at chat rooms and web scraping, I don't know what else people are doing these days, and provide interesting information that you can take to maybe decide on new target populations and new types of data collection efforts. But you want something that is scientifically defensible for the FDA. You don't want something that's very ad hoc. Ad hoc is great for giving you ideas, but not necessarily for making policy. It's just not going to hold much water. That's my feeling. Okay, so there are lots of interesting approaches that survey methodologists are involved with, and other people here probably can speak to that. Someone mentioned network sampling. Is something I was involved with back in the 1970s, and I guess it's still being used. The other thing that actually, or general approach might be to, if you can get these various data sources to do consistent collection of information, you could maybe design some multiple frame type methods where you get better coverage of these hard to get populations along with standard household survey populations, and collect the information that you need to do the proper adjustments for the fact that they can be included in more than one survey at a time, and you can combine these data sets together. That's about all I have to say.
Okay.
I'm sorry. I was just going to ask a question about, a lot of times here we're talking about sampling. Where does, for FDA, the whole structure of using administrative type data fall? Because even though they're not sampled necessarily, sometimes they're A, not universes in their entirety, as we've been talking about, and B, sometimes they're used for different functions, and there are changes in, say, local policy or local coding practices or other things that affect the ability to make decisions. That's not exactly sampling, but it is tied to assumptions about the data, and that might be covered elsewhere in the conversations, but I just wanted to raise it.
This is Judy Staffa. Actually, yes, we use administrative claims data and EMR data to look at traditional drug safety issues all the time. And we've actually put out a guidance. I'm trying to remember what year, I'm getting old. We put out guidance in the last few years about good practices for how to use those data. And a lot of the way we deal with that is to do validation. So for a drug safety outcome, we often don't trust an ICD-9 code unless folks have actually gone back to the charts and looked at this to ensure us that when that code is used, generally it means the patient had this condition and it's not a rule out or a lot of the other reasons why those codes are used. But we also do take into account whether they're commercially insured populations or publicly insured, and so we deal with those generalizability issues all the time.
Oh, yeah, exactly. And I think it's something across the federal system. There's been a lot more and more interest. There was the Federal Committee on Statistical Methodology, FCSM, had the Administrative Records Subcommittee that then got subsumed under the loosely put Big Data Committee. And so there's a number of issues like this that are being looked at the overall federal level, and to the extent that there are resources that the new OMB Chief Statistician and FCSM can provide FDA to come up with to supplement some of the work that you've done. I don't know if that's another area that might be useful.
Can I just follow up on that as well? Within HHS, the Data Council often talks about these issues. ASCII is co-chair of that with CDC and AHRQ, so that may also be another place as you're coming out of this meeting with specific questions that other statistical agencies within HHS may be able to assist.
Dr. LeRae, then Dr. Winterstein of the University of Florida, and then Dr. Green.
Yeah, so I actually think that Dr. Schnoll's suggestion about the two different populations of patients are actually very interesting. much of what we've been discussing have really focused on people who are prescribed ADF opioids, but I think we need to think about the other population of people who are receiving those drugs not in a prescribed format. And I think we're going to need to think about when do those, when, in terms of thinking about sampling those people, when do they actually come to attention and in what settings? So, for example, are you going to sample people from outpatient, hospital emergency department settings when they come to present at the time of overdoses? Are you going to present based on legal, from in jails and prisons, people who are incarcerated because of diversion? I think also you're going to need to think about differences in geographic, differences in different regions, differences in urban versus rural settings, in order to get to draw, I think, the most generalizable results. So, I mean, I think it's going to be challenging in terms of thinking, particularly for this other population, of how to select these people appropriately. But I think if you come up with, certainly stringent, systematic standards, it certainly can be done.
Dr. Winterstein?
A good part of the discussion has focused on sampling, and I'm looking at this question again, and I see analyses under biased sampling. So I think it looks like the majority, or the focus of this question is really the sampling has already occurred, and we have a biased sample, and what do we do with it now? And I have been staring in particular at this first bullet. To me, that is an oxymoron. If I don't think that there is, or if I don't know whether there are specific effect modifiers that because of the sampling approach somehow skew the population that I'm analyzing, I don't think that I can make assumptions. So at the end of the day, I think it comes down to pinpointing what specific mechanism would create a biased sample that then produces a biased answer, right? So to make that more direct, if I in a treatment center analysis see that a particular drug is particularly frequently abused in an intravenous route or whatever, then the question would be, is that representative of that use of that drug in the underlying population of opioid users, right? And why would that not be the case if that population is not properly represented? And the only way to get to that answer is if we have some ideas what those effect modifiers would look like. So now those two big buckets of prescription users versus illicit users may produce some help there, because with the prescription users, we may be able to link data. That goes back to the administrative data. So if we were able to characterize the population that we see in a particular survey, assuming that this is identifiable information and that may or may not be the case in a particular scenario, we might be able to start to characterize this population. Are these more older patients, younger patients, rural areas, not rural areas, what have you, and try to see whether there are specific effect modifiers that we could pinpoint. That's my only answer I have, because I think without understanding that mechanism that would produce a biased answer, we cannot do anything with biased sampling.
And Dr. Green?
So if we look at the 5 outcomes that we are trying to measure, they all are related to aberrant behaviors, which upon reporting may also have other consequences. And so this isn't trying to, find how many people generate a rash with a new hypertension medication or something like that. So I think by nature we have to rely on spontaneous reports and these convenient samplings, because something has happened, an event or something has occurred that actually bring these people to the point of revelation or revealing themselves. And so I don't think that makes the data invaluable, or that we need to be careful not to throw all of that, the baby out with the bathwater. And I wouldn't expect calls to poison centers to represent the general population or everything that goes on. And I think we're very cautious, even with treatment centers, that this is hopefully representative of patients seeking treatment. And I think we've identified the gap that we don't know if people with addiction or dependence that aren't seeking treatment are any better. But then also go back to, we're looking at trends over time. So we're looking within each of these populations, and the mosaic approach, there's a reason why we're getting so much data from different data sources. So while I think there are minor improvements, I think to Dr. Novak's point, that we can make in the sampling, or at least understanding that's representative of that subpopulation we're studying, I wouldn't expect each one of these to represent, the larger population. And again, back to that mosaic approach of the value of understanding all these subpopulations, and are the trends moving in the same direction.
Actually, this is Judy Steffa. I want to follow up with a question about that. I think that's actually one of our key questions, because we've seen examples where if you look at different samples of treatment centers, you get a different answer. So that begs the question of, do either of these represent the larger population, or what is it about these different groups that are pulled together that might make them different? And so is there something we can push and begin to learn more about where these different populations are coming from, so that we could, even though we may not understand it completely, we can at least understand what it is we're looking at?
Yeah, and I think that's where you go in and you look at the risk factors or descriptions within your data at that point, right? So I know we have a program that looks primarily at publicly funded programs, and one that looks primarily at privately funded programs, and those are very different patient populations. So we know that there are some differences in there, but then you can start evaluating your data sets to say, are there specific risk factors? What are the differences between these that might lend to further understanding of what happens after a certain intervention, whether it be ADFs or the REMS programs or PDMPs, whatever that looks like. But I think that we need to understand that, is that really a selection bias? Is that really a problem with convenience sampling, or is that an opportunity to further evaluate the differences within that population and understand different risk factors, and maybe what interventions might work more effectively in, say, a lower socioeconomic group than a higher socioeconomic group?
Thank you. If you have additional discussion points on question 1, take the opportunity to put it in the docket. I'd like to move on to the next question, question 2. Okay. So, discuss methodological approaches that address changes in the studied population over time. For example, changes in individual geography, changes in demographics, etc. So who would like to go first?
This question confused me a little bit, to be honest, because there are, individual geography and individuals are usually kind of immutable units, right? But there are, in terms of time varying confounding and temporal changes to what you're observing over time, there's the temporal changes in sampling, and then there's the temporal changes in individual level risk. So I'm curious, which are you more interested in understanding at this point?
So let me clarify that up. So in terms of the geography, the example goes to the treatment center data. And the treatment center data that we worked with, they're part of a network that collects those data. And the treatment centers participate in that network. So a treatment center in California that participates now, 5 years down the road, they may not participate, or the number of centers in California is declining in terms of participation. So the mix of individuals that provide information from one region is now, while they were well represented in the initial part of the surveillance, later on, they're no longer well represented in the surveillance. So in a sense, the underlying statistical information is changing, where there's emphasis early on from California, but now less emphasis from California. So it's sort of like meta-analysis, where you have different clinical trials at different centers providing different information, but then there's the question of they have to come together at some point. So in that sense, the demographics maybe in California and the representation in California may be different from one period to the next as part of this surveillance system.
Got it. So you're interested in the sampling, on the sampling side. So at the same time that the sampling may be changing, you know, the number of treatment centers in California may be going down, there's also an inherent bias in the ones that are more stable too, right?
Right.
So it's not, so I don't see it as like a one or the other is better approach, right? And I know in earlier treatment center and other programs, you know, there was a stratified, you know, there were stratified tables where it was here are the centers that have consistently reported over the last, you know, 50 quarters or whatever it is.
Yeah.
And so, I mean, that approach could be brought back. Would that be satisfactory? Are you looking for something a little bit more fundamental?
We've actually considered the approach where we restrict the sites that remain consistent over the study period. But when you do that, the amount of statistical information is reduced substantially. And we were wondering, like, you want to maximize and optimize the amount of information. If you want to use every piece of information that you want, and these stuff are happening, what is there analytical approaches that you could do to try to address those issues?
So I think what Dr. Winterstein...
Can I just clarify? This is Dr. Dasgupta talking. I'm just thinking of the transcribers.
Sorry about that. I'll just respond quickly. So I think Dr. Winterstein's comments suggesting, look, you know, what are the effect modifiers, I think is the right direction to go for that, right? Where you don't necessarily, I wouldn't think about restricting, I would think about stratification, right? And with stratification, you do it carefully with a priori hypotheses, and these are the effect modifiers at the treatment allocation, at the treatment center level. And maybe what's missing now is that we don't collect time-varying information from the treatment centers themselves, whereas we collect serial cross-sectional data on treatments, on the people coming into the treatment centers. So if we, you know, additionally, in addition to the people coming into the treatment centers, we can also sample the treatment center providers themselves and say, you know, do you, for example, like, are you now providing Vivitrol? You know, maybe that makes a difference. Are you, you know, did you drop Medicaid coverage because of ACA, whatever? You know, I think we could collect data at one level higher on the treatment center, kind of on a clustered level, to maybe get you at some of those stratification dimensions.
Dr. Brooks?
Turn myself off. John Brooks. Yeah, you know, listening to this conversation, it reminds me of a surveillance system we use in our HIV division extensively, the Medical Monitoring Project, which might be a model you might be interested in looking at. It's a 3-stage sampling survey that's serial cross-sectional surveys, and folks are sampled both at the provider level and clinic level as well as at the patient level, and then interviewed in serial cross-section fashion generally annually right now. And you can design a system to do your sampling that, depending on the population you want to study and what you know about that underlying population, you can sample people and determine their representativeness of those folks you're looking at and weight their contribution to the ultimate score. The way we use it is to understand how people are receiving care among persons who are enrolled in HIV care. But if you were interested in persons, just one of the basic questions, to understand by what route of administration are people abusing drugs. You know, you'd aim to sample, I imagine, at places where the clinical environment will encounter those people. So not only people coming in for drug treatment, but perhaps jails and prisons for people who come in and are demonstrating withdrawal, you know they're using, or mothers presenting with neonatal abstinence syndrome. But you could design a system to capture people experiencing the clinical consequences of abuse, and then use that as the model from which to sample your group. And if you want more information about that, our group who runs the system is very familiar with it.
Yeah, I agree with what a lot of has been said so far. I think you have to make choices about particular populations, especially when you have so many moving targets, because you have to have something that's sort of fixed in order to monitor change over time. So thinking about your treatment sample, for example, a lot of people enter treatment because of law enforcement contact. States that have legalized marijuana are going to have differential law enforcement contact post-legalization than pre-legalization. And so that's going to really affect who's in that sample. So you really have to understand how people get into the treatment system and make choices about those populations. And so I think that gets back to that first question. You can't not make assumptions. I think you should make assumptions and then choose samples that are sort of fixed, that can be reasonably fixed over time. And you just have to make choices and lose power.
I actually just have a question about the sample that you're talking about. Are you actually sampling these treatment centers, or is this a fixed network that you don't have control over? And I think the difference is whether you're taking a sample from a frame of treatment centers, or whether there's external reasons why they're participating in the first place. And that I apologize for not knowing your area.
Right. So let me clarify that. So the data that we get, they're from treatment centers that are part of a network that we have no control over. So a lot of the evaluations that we do in the ADF space is looking at the data that comes from this network that collects data from these treatment centers. So that the treatment centers, I think they volunteer to participate as part of the network that collects the data.
I'm sorry, could you also say what research questions get answered by these data?
One of the research questions that we evaluate in FDA is, does the product that's been labeled in the pre-market setting, labeled with ADF language, does it really reduce abuse in the population out there in the community in the post-market setting? And so we have access to these data, or at least through submissions, and we have to evaluate whether the product results in reduced abuse in the community or not using these data.
This is Judy. I think if there's folks here at the table from Radars and Inflexion, the companies that actually run these networks, and perhaps they can just briefly explain what are some of the, why do treatment centers participate in these networks? What do they gain from that, so folks can understand the incentives? They're not sampled in a probability design. They participate for a purpose.
Hi, I'm Teresa Cassidy, and I work at Inflexion, and some of this treatment center data that we're talking about is data from the ASIMB NaviPro data set, and it is a convenience sample. It is a heterogeneous treatment center sample where it doesn't necessarily just have, only, inpatient, outpatient, has a mix. It does, in some respects, reflect the heterogeneity in, substance abuse treatment in general, in that regard. But in terms of how the treatment centers participate, is we have this network where individuals. One thing to sort of keep in mind about this data set is that the Addiction Severity Index, the ASIMB itself, is a clinical assessment. It has clinical utility, so it's used for that purpose. In addition to that, we have included product-specific information for prescription medications and product-specific route of administration data. So the data are being collected initially for clinical purposes for substance abuse treatment centers that need to use this for their clinical evaluations to assess the need for treatment. And then we're collecting that data on the back end and aggregating that to be able to try and look at some patterns and trends in prescription opioid abuse. There are treatment centers that consolidate and close down, and some new ones come on board. There is a dynamic aspect to the different treatment centers over time, but there is a bit of consistency in terms of the general number of and the types of treatment centers that we have. I think, just to get back to the example that was sort of raised at the beginning of this question, was if we have treatment centers in California and they're somewhat, they've decreased over time, and then there's some treatment centers in Michigan and they're sort of increasing over time. I guess it goes back to what question are you trying to answer as it relates to these, the data. And, if we think that, the treatment centers, having a smaller group of them in California are fundamentally different from the group that existed, in some previous time period in this system in California versus they are fundamentally different from individuals who are, seeking and being assessed for treatment in Michigan, say, as it relates to a specific product and how people would use or abuse a specific product. I think you're right that, if we're talking about trying to get, if the question is we want a national estimate, then, these data would need to have some type of enhancement and, support and help to make that happen. And I think that there are probably methods and approaches that we could use to do that. I think if we're talking about what questions do these data answer, I think that we need to kind of keep that for the moment. We need to keep that in perspective. So I guess going back to some of what Dr. Dasgupta said is I think stratification, talking about the different risk factors in the underlying the patients and the individuals in the population, and looking at them rather than saying well, it's just geography. California isn't as represented as X state. Maybe geography is a component, but it's not maybe the focal point.
Dr. Grauer?
So I'm also a little bit confused exactly about the question, but I think I have a little bit of an idea now. So there's these treatment centers that are decreasing in some states and increasing in other states. There must be some sort of a listing of treatment centers in the United States. And if you could get information about the characteristics of these treatment centers so that you can make adjustments either through weighting or through stratification or analytical adjustments for how things are changing. I mean, this happens all the time. Anytime you're dealing with any sort of a panel type study where units are dropping in and being born and created, this happens all the time. And so there are statistical approaches and that people have used. I'm not saying they're perfect, but that you could take account of. You're a statistician, and I'm sure you know these. But so it's kind of a combination of missing data issues and also adjustment standardization type approaches.
Okay. Okay. So let's move on to question 3. Yeah, this one is discuss the usefulness of these metrics for measuring and assessing the impact of ADFs on abuse-related outcomes in the population. So sub-bullet 1 refers to the number abusing product X as a proportion of those denominators. Sub-bullet 2 refers to number abusing X through some route R based on a similar set of denominators. And then sub-bullet number 3 refers to the number abusing X relative to the various utilization denominators that I've listed. And also discuss metrics that we have not considered that you think might be potentially useful for the current data sources that we have. And also discuss interpretations when different metrics imply different conclusions. Dr. Dasgupta?
Thank you for bringing up these questions. So I'll speak to sub-bullet 3 of bullet 1. So one of the distinct challenges we've heard with the newer ADFs is going to be low volume, right? We're talking about 5% of the opioid market. And we've also heard, we also know from talking to people coming to syringe exchange programs, drug users, that what people use is really, has a lot to do with what's available to an individual within a social network, within a city, within a neighborhood, whatever it is, right? You're not gonna, so the approach that has been taken to date has isolated each drug and compared it to one comparator, or maybe a handful of comparators. But we don't do much to look at and I know FDA's remit is to look at specific products, right? But if we are looking at the basket of opioids that are available to any given individual, in any given community, I think there's another conceptual piece that we're missing, right? So if you're looking at one like very low volume ADF, but that area is awash in hydrocodone, but also has like a substantial amount of oxymorphone, say. And if you go through and kind of look at the different opioid active molecules and look at kind of the mix, the concentration and competition almost, you'll see that there's wide disparities across the US. So in the economics literature, there's competition in markets is quantified using a handful of indices where you see kind of what market share each, the product of interest has relative to other major products in that market, and kind of to standard bearers. And so I think part of the dynamic that happens in a real world, I'm trying to get my drugs to get high setting, is that you end up using what's available. And right now, when we use sub-bullet 3, we are making an assumption that there is a uniform availability of that product for every individual in that geographic unit. And I don't know that when you're talking about high volume drugs, that's kind of reasonable, but when you get to some of these very low volume drugs, that's going to fall apart completely. So in some ways, adjusting for the number of prescriptions is something we have to do to get our mind around the comparisons we make. But at the end of the day, looking at each drug in isolation is going to kind of put you in a tunnel vision.
Captain Jones?
I think, to me, the one thing that's missing is that you're comparing X to any opioid. I mean, it's sort of getting to some of the same point, but I mean, the literature is pretty clear that people have preferences, and those preferences for specific opioids are due to a multitude of reasons. So if you have, a new extended release hydrocodone product that's, reformulated to deter abuse, thinking about all opioids versus maybe thinking about other hydrocodone products or other products that are similar, I think is an important nuance to determining impact. I mean, we sort of dealt with this with the hydrocodone upscheduling issue where the comparator was chosen as oxycodone combination products, and some people would argue that that might not be the best comparator, that if you look at abuse ratios for morphine or other things, it might be different. So I think it's important to not just lump all opioids together. That could be one measure, but I think also looking at comparators, which I think you're going to talk about later, but it's not specifically called out here, and I think that it should be a part of the metrics.
This is Judy. I wanted to just provoke this a little bit. We've had a lot of animated conversations with our colleagues in industry about which metric makes the most sense to answer this specific question. So if you can focus, what is the right metric? Because many times these metrics, you can look at the same data, calculate these different metrics, and you get a different answer. And so we'd really just love some scientific insight on if you had this in front of you and you had to answer this question, which metric, in thinking about, again, the question is about whether the abuse deterrent formulation is deterring abuse via the route that it was formulated to do so, and assuming, which we'll get to later, that it's a correct comparator, or whatever you're comparing it to. But what is the right? Should you adjust for utilization? Do you look at the proportion? Really, if you can help us here, this is, there's no right answer here, but we need to understand, we need to get someone else's thoughts. We've been talking to ourselves about this for too long.
Dr. Green.
Within the drug utilization options listed, I was surprised to not see milligrams dispense or some adjustment for tablet size, because I think we all know that a 5 milligram tablet is much different than an 80 milligram tablet. So I guess I'm not sure if there was some reasoning behind that, or it just hasn't been discussed.
No, I think there's so many ways to adjust for utilization, we just picked one. So if you think, so does that mean, Dr. Green, that you think utilization adjusted has value to answer this question? in some way, whether it's
Yes.
by tablets or milligrams or prescriptions.
Yeah, I certainly do in some way. I think, again, back to the question and even the population, and you have to look at the coverage of where your data are coming from. But in relation to all of that, I do think it's important to understand, because I think the population certainly gives you that overall public health burden aspect, but drug utilization does give you the risk associated with the specific product. Now, looking specifically at the drug utilization options that we have, we've gone through the ERD, unique recipient, and prescriptions dispensed, and then tablets dispensed. But if you're going to compare, say IR products to ER products, or products that have very different wide range of milligram strengths, then I do think that a milligram dispensed is going to be a much more appropriate level of the drug utilization data to use.
Dr. Bai.
Make it quick. I want to move on to one more question before we end this session.
Sorry. So when you use the number of dosage units instead of the number of prescriptions, there's going to be certain products that are going to jump out as being much worse than you previously thought. Fentanyl is the one in particular that stands out. So I think the question is going to also be kind of which drugs are you comparing, and kind of goes back to the comparator issue as well.
Thank you. So I'd like to jump ahead to question 5. Is it? Okay, thank you. So pre-post comparisons have been considered extensively in the context of measuring change between a pre-ADF period and a post-ADF period. Discuss criteria that you think may be useful for determining the length of the pre- and post-period. Discuss the balance between the ability to observe trends and the changing population characteristics.
Captain Jones.
I just have a question on this. Obviously, OxyContin is the product that has been studied the most in this space, and you had, a fairly good pre-period where there was social capital associated with the name, and you can look at post-reformulation. You don't have that for some of the newer products that are essentially new formulations. Or in the case of like Hysingla, where you had Zohydro on the market for a relatively short period of time, virtually very little pickup, so your pre of something similar doesn't really exist. So I don't know if there's a question around that particular issue, but this seems to assume that you've got pre for everything, which you really don't.
I mentioned earlier that there are some products that we know it was never marketed without the ADF formula, with the ADF formulation, and for those products, there's no such thing as a pre-period, and so we're still interested in the effect of the formulation for those products, and it's not entirely clear, at least not in this session anyway, how you go about and defining a pre-period.
Right. This is Mark Levins. I think your question is going to be somewhat more addressed in the causality section in the afternoon.
Dr. Winterstein.
I don't know exactly the structure of the survey data and how much they lend themselves to being chunked in tiny little time units, but there's always an advantage over having a time series analysis rather than a pre-post, because you can appreciate trend. And considering the amount of change that has in parallel happened that we all are very well aware of, I think it's extremely difficult and dangerous to just grab one particular time point and assuming that this can be attributable to the marketing of ADF formulations. So I think optimizing the time increments that can be used and still yield reasonably stable and reliable results, but putting them in a time series framework would be always more advantageous than trying to identify a pre-post design.
Dr. Lowry and then Ms. Cassidy. No? Okay, Ms. Cassidy.
Yeah, I just wanted to comment about the time period, and to some extent this might be product specific. So boxing ourselves into like it has to be a specific time period for a specific length of years may not make sense for all products. So you could have a specific product that maybe shows great promise and success in a certain period of time, and you can see that evidence and supportive, convergence of data across a number of different data sources and studies, and then that makes sense. But for another product, maybe that there's sort of maybe milestones or gates that it goes forward in time, and you would need to take a look at. So I would just caution us from not boxing ourselves into, there's a specific number of years or a specific period of time that needs to occur.
Captain Budnitz?
Dan Bund at CDC. I was going to actually make essentially the same point, that the time period is going to be dependent on your expected delta, how effective you think the abuse deterrent formulation is going to be. And if you expect less effect, you're stuck with a longer post period to try to evaluate it, and then you do have to balance all these changing population issues and other issues. So I think that's like your first step, is coming up with what is your expected delta. And it may be infeasible if it's so low that you can't do it.
Dr. Brooks?
Yeah, John Brooks. I just want to echo, I think, what Dr. Winterstein was getting at, which is I find pre-post comparisons in an environment where the ecology of the forces that are changing the prescription and availability of these drugs are all changing so quickly, it's going to be very difficult to tease out to what extent the change in formulation led to the observed change in the, whatever your outcome is, use, abuse, Pre-post are terrific if you have a very, very stable system. But where there's a lot of other competing causes going on that could lead to the outcome you're looking at, it's very challenging.
Dr. Ciccone, so I'll just highlight, I'm going to repeat some of the things I just said and also go back to what Nab was saying earlier, Dr. Daskupa, and that is there's a lot of fungibility in this opioid world, and now that there's a number of new products that have come out, ADF products, as well as competition with the heroin and fentanyl market, we just need to be aware there's going to be a longer period is going to be necessary to observe what the cultural changes are going to be, which opioids become dominant, what are the the competing effects. I would agreeing with Chris Jones that we need to compare the denominator needs to be compared. How is this drug doing compared to the opioid pool in general? So those are my thoughts. And a cultural lag time. It takes a while for the culture to not only figure out how to get around a weak abuse deterrent formulation, but then to pass it on in the 100th monkey way, months to years.
Captain Jones, before we move on to the audience participation.
Yeah, so I agree that it's important to see what stabilization looks like over time for different products after they're introduced. I think similarly on the front end side, on the pre side, it would be good to have some historical perspective. I think if you look at OxyContin, some of the studies that have largely based on the data systems that have been available that coming online 2008, 2009, there was a lot of talk about the reformulated product before it was actually in the market. And you see in some of the studies this slight uptick in the pre-period, which makes the post-period comparison greater. But if you look back in other years, like we did a study with NISDA data where you have some more years of data, if you look at where things are like a couple of years after in the NISDA data, yes, it's maybe less than the peak, but at historical levels, it's still high. And there's the question from the public health perspective of what is acceptable lowering of abuse. If it's as high as it was when people were still abusing it and dying, have we really made a public health gain? And I think that's important, that you may not, obviously for some products you won't have that historical perspective, but I don't think it should be just based as best we can on the limitations of the available data sources.